This is a video in clinical medicine from the New England Journal of Medicine.
This video demonstrates how to remove and replace a balloon gastrostomy tube. Indications, contraindications, placement technique, and potential complications will be reviewed. A gastrostomy tube, or G-tube, provides long-term enteral access for nutrition in patients who are unable to eat and may occur in patients with cancer, stroke, traumatic brain injury, or other conditions. A gastrostomy tube may need to be reinserted after accidental dislodgement, or it may need to be removed and replaced because of a malfunction, such as tubing that is cracked or a balloon that no longer works. G-tubes may be changed on a schedule to prevent malfunction. Contraindications to gastrostomy tube exchange include the lack of proper equipment, the absence of continued need for a G-tube, or placement of the tube within the previous 6 weeks. A gastrostomy tube is inserted through the skin into the stomach. It has an internal component, such as a balloon, to prevent it from falling out of the stomach. There are different types of tubes. Some gastrostomy tubes are fitted with a deformable plastic mushroom. This type of tube is placed by means of the percutaneous endoscopic gastrostomy technique, also known as the PEG procedure. This video demonstrates the replacement of a gastrostomy tube that has a water-filled balloon at the tip. Replacement of other types of G-tubes may require different techniques not demonstrated here. The balloon tip tube has a valve port, which is used to insert water into the balloon. The standard PEG tube that is fitted with a mushroom tip does not have such a port. The patient's enteral nutrition does not need to be restricted or discontinued before the tube is changed. To prepare the patient for the procedure, the patient should be in a supine position. The head of the bed may be raised to 30 degrees if that will make the patient more comfortable. Next, inspect the tube that is already in place, noting its French diameter designation and the volume capacity of the balloon. Also note how deeply the tube has been inserted at the surface of the skin and at the top of the external bumper in centimeters. Sometimes all the markings may be worn off the G-tube. Before beginning the procedure, gather the following equipment: a replacement gastrostomy tube with the same French diameter as the tube that is being removed, water-based gel lubricant, a 10 milliliter syringe filled with water, a 60 milliliter catheter tip syringe, and clean gloves. Before using the new tube, test the balloon. First, note the amount of water needed to fill it. Fill the balloon with its maximum volume of water and look for any sign of leakage. If there is no leakage, remove all the water from the balloon. Lubricate the tip of the new gastrostomy tube. Ensure that the external bumper is able to move down the tube. During storage, the bumper often becomes stuck to the tube. Moving the bumper at this point will be much easier than moving it after you have inserted the tube through the gastrostomy site. With an empty syringe, aspirate the water from the balloon port of the existing tube. Make sure that all the water has been removed by re-aspirating if necessary. Have a gauze pad ready to absorb any drainage, and then remove the tube. Then gently insert the new tube until it is a few centimeters past the previously noted skin level centimeter mark of the previous tube. This is to ensure that the balloon will be inflated when it is in the stomach, not in the gastrocutaneous tract. Now with the balloon tip well into the stomach, inflate the balloon with water. The patient should not feel pain as you fill the balloon. The presence of pain should alert you that the tube may have entered a false passage rather than the stomach. Gently pull up on the tube until you feel slight resistance from the inflated balloon against the inner gastric wall. Then push the external bumper down, but not too tightly. It should be easy to spin the tube, and there should be a gap of about 2 to 3 millimeters between the skin and the bumper. If the outer flange is too tight, it may cause necrosis of the gastric mucosa. The centimeter marker at the top of the external bumper should be set to the same measure at which the old tube was set, assuming that the previous tube was not set too tight and the balloon was fully inflated. Confirm intragastric placement by aspirating gastric contents. This indicates that the tube is ready for use. If you place the new tube without difficulty but are unable to aspirate gastric contents, then connect the new tube to a drainage bag and allow drainage to occur through gravitational flow. If the gastric contents appear in the bag within 20 minutes, intragastric placement can be considered confirmed. If no gastric contents appear in the bag within 20 minutes, fluoroscopy should be performed with water-soluble contrast at an oblique angle to confirm intragastric placement. The most serious complication of gastrostomy tube exchange is the placement of the tip of the tube in a false passage within the subcutaneous tissue, or in an intraperitoneal location rather than in the stomach. The administration of nutrition through a tube that is not in the stomach can be fatal. A supine abdominal film taken after the administration of contrast material into a G-tube, as shown here, is not reliable for confirming intragastric placement. This radiograph gives the impression of correct placement. But an oblique view of the same patient, obtained with the use of fluoroscopy, reveals that the contrast material is actually flowing into the stomach through a subcutaneous tract. This tube is not in the proper position. This radiograph shows the tube after it was repositioned in the stomach with the use of a guide wire and fluoroscopy. It is important for providers to be comfortable with gastrostomy tube exchange. Understanding the procedure and its potential hazards should help to minimize the risk of complications.